Hello, everyone. Thank you for joining us. Welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Casey Minnis. I'm Director of Communications for MS Focus, and I'm joined today by Daniel Kantor, MD, who will be talking to us about managing MS relapses. After a presentation from Dr. Kantor, we'll open it up to your questions and comments. Now I'm delighted to introduce our speaker. Dr. Daniel Kantor is President Emeritus of the Florida Society of Neurology, the founding president of the Medical Partnership for MS, and a longtime member of the Multiple Sclerosis Foundation's Healthcare Advisory Panel. He practices neurology in South Florida. We're pleased to have him join us and present this important topic. Dr. Kantor, thank you for being with us, and I'll turn it over to you.
Thank you very much for having me, and thank you for joining us today. We're going to talk about an important topic that's not always talked about. We're going to talk about what you need to know to manage an MS relapse. Another way of talking about this is to talk about how to be the most successful. Many of you may or may not have seen this image, but this person was ice skating and fell. And she was weak for several months. Then she lost vision in one eye, and she couldn't see very well out of one eye for several months, and then it got better. She kept on having bad things followed by good things happen to her. And because of that, Saint Ludwina was sainted by the Catholic Church and made the patron saint of ice skating. In multiple sclerosis, we like to think of her as the first person in recorded Western history to have had multiple sclerosis. Most people with multiple sclerosis have what we call MS relapses. Another way of talking about relapses is calling them flares or attacks. We used to call them exacerbations, but actually neurologists got exasperated by patients or people with MS calling them exasperations. And so we moved to the term MS relapse. But whether you call it an attack or a flare or an exacerbation or frankly an exasperation, what we're talking about is when you're doing basically okay and then new or worsening of older things, but usually it's easier to see when it's new problems start to arise. And those don't always come on immediately. In fact, more often they don't come on very quickly. They come on slowly and then you notice it. And then they stick around for a while and they can affect your walking or your thinking or your feeling or your vision or other parts of your central nervous system. And that's when we're talking about an MS relapse. Whenever we're trying to figure out if a person with multiple sclerosis is having an MS relapse, it's important to return to what we call the patient's exam. And that means not just the exam that the neurologist does for themselves, but keeping in mind what Sir William Osler said more than 100 years ago now, that the best teaching is that taught by the patient himself. Now, he was in 1903, so we'll forgive the latent chauvinism. He didn't say herself or themself. But that part is still true today, that we think that the most we can understand about multiple sclerosis is when we take into mind not just our perspective as the neurologist and the other healthcare professionals, but your perspective as the person living with multiple sclerosis, as well as the family members and the loved ones around you.
Pardon me, Dr. Kantor.
Yes.
Let me interrupt you for just one moment and let you know that your slides aren't advancing on our screens.
Okay.
You may want to close screen sharing and restart it on your slides to see if that reconnects it.
Absolutely.
There we go. Now we can see where you're at.
Okay, great. This was the image of Saint Ludwina. She had fallen and gotten better, and she was made the patron saint of ice skating. As we said, the patient's exam, or the person with multiple sclerosis exam, is very important. And that brings us to this concept of the multiple sclerosis team approach rule. And the idea of the multiple sclerosis team approach rule, or MSTAR, is very simple. It's to place the person with MS at the center of the team. And while many of us may think, or others may think we're important, such as the neurologist, the nurse practitioner, the physician assistant, the MS nurse, the social worker, the case manager, the physical therapist, occupational therapist, speech therapist, or primary care physician, we are background players. We are there to give advice and to give counseling to that most important person, you, the person with MS. On the other side of the star, you see the people that are even more important, the friends and community, the significant other. And in multiple sclerosis, we often talk about MS partners, not MS caregivers necessarily, but MS partners and the family. And then we can think about how the job is important. And I know in today's trying times, jobs are difficult for everybody, but we're blessed to live in America where when it's time to keep your job, we have the American with Disabilities Act to help you maintain your job and to have reasonable accommodations. And when it's time to ask for disability, we also have that. And then the MS team is made up, of course, of the MS community overall. And that involves large and small nonprofits such as the Multiple Sclerosis Foundation or MS Focus, other large nonprofits such as National MS Society, the Multiple Sclerosis Association of America. We have other smaller not-for-profits such as MS Views and News, and then we have much smaller not-for-profits where people are making keychains and people are making bracelets to support people with multiple sclerosis. And whether it's part of a nonprofit or not, the MS community is here to be by your side, to help support you as the person with MS. I think it's important when you're talking to your neurologist to make sure that you're using similar language and to make sure we're talking about the same thing. And that's why I like to talk to people about what I think MS is. And when I say think, what I mean by that is that we don't know for certain. And every 20 years, half of what we know right now in medicine is found out to be not just a little bit wrong, but to be 180 degrees wrong, to be completely wrong 20 years down the line. But what do we understand about multiple sclerosis right now? We think of MS as being a lifetime diagnosis, as having to do with the autoimmune system. So meaning that your body's immune system, instead of attacking just outside invaders like viruses, fungi, or bacteria, the body also goes and attacks yourself. And when the body attacks the joints, we call that rheumatoid arthritis. When the body attacks the pancreas, we call that diabetes mellitus type 1. And when the body attacks the nerves and the covering of the nerves, we call that multiple sclerosis. It involves the central nervous system. The central nervous system is made up of the brain, the optic nerves, as well as the cervical and thoracic spinal cord. We think of the spinal cord actually as being more involved faster and earlier than even the optic nerve or the brainstem. We involve not just loss of myelin or white matter loss, as well as axonal loss, so problems with the wires that have to do with nerve conduction as well. We think that MS happens in a person who has some sort of genetic predisposition, not meaning it's necessarily passed down from mother to child, but that there are some sort of genetic predispositions, and we have a lot of genes that now are associated with MS. And then there's some sort of environmental trigger. Michael J. Fox was talking about Parkinson's disease, which is not related to multiple sclerosis, we don't think. He said that in Parkinson's, genetics loads the gun and environment pulls the trigger. We think of that same sort of thing in multiple sclerosis, where this complex interplay between what's happening in someone's genetics or their genetic background, as well as the environment, come together, and that leads to multiple sclerosis. But we've talked about what MS is, we can also talk about what MS is not. We do not think of MS as fatal. We do not think of MS as contagious, not directly inherited, and it's not always severely disabling. MS is a reason to continue working. It's not a reason to stop working. It's not a reason to stop doing the things that one enjoys. And it's not a reason to not have children. When we think about multiple sclerosis, it's a good idea to have a little bit of an image or a picture of what we're talking about. In that center, you see that nerve fiber, that axon, and around it is that myelin, is that white matter covering. And we think that the immune steps that lead to neurological problems are that we have some sort of activated T and B cells, and that they cross the blood-brain barrier, They get inside into the central nervous system and they launch their attack. And that attack can lead to the symptoms of multiple sclerosis. And here's just another way of looking at that, where these activated T and B cells can send out chemical messengers, such as cytokines, which simply mean messengers that come from cells. And that can lead to the damage that we see in multiple sclerosis. Now, at the end of today's talk, we're going to have a pop quiz where we quiz people about every aspect of this image. But in all seriousness, we're learning so much about multiple sclerosis. And every week to month to year, we're learning more about different types of cells that are involved in causing and leading to the problems of multiple sclerosis. When we talk about MS, we try to use a common language. And that common language has changed a little bit throughout the years. Most recently, we've talked about three main subtypes of multiple sclerosis: relapsing remitting multiple sclerosis, secondary progressive multiple sclerosis, as well as primary progressive multiple sclerosis. Relapsing remitting multiple sclerosis, as well as active secondary progressive multiple sclerosis, is what the FDA or the Food and Drug Administration terms relapsing forms of multiple sclerosis. Relapsing forms of multiple sclerosis includes not just people who have waves of relapses that come and go, and not just people who start out with these waves and then may have progression even in between. We call that active secondary progressive multiple sclerosis. But also people even earlier on who have that first attack of what's going to become multiple sclerosis, and we call that clinically isolated syndrome. And then 15% of people say, what are you talking about? Things getting better and things getting worse. Things have just consistently gotten worse since the beginning. And we call that type of multiple sclerosis primary progressive multiple sclerosis. And until just several years ago, we did not have treatments for primary progressive multiple sclerosis that were FDA approved. And now we do have a treatment that's FDA approved for primary progressive forms of multiple sclerosis. And we have more research going into that as well. So what happens in the neurological evaluation? What are the secrets that we as neurologists do? Well, we take your history and we ask a lot of questions. And we ask them in different ways to try to come up and understand better about what's going on with you. You have to remember, we haven't been there every step of the way with you. And so we have to understand who you are as a person and also understand how your story led to your diagnosis or is leading to the questions that are surrounding your diagnosis. We'll use physical examination. And that physical examination will involve a lot of the Simon Says of lift up your arm, touch your nose, oh wait, don't do that, reflexes, and all these sorts of things that we as neurologists do. We also may order tests, we may order labs, we may order MRIs and other kinds of images to help us. There may even be specialized testing, such as evoked potentials, electrical tests where we put electrodes on your head in order to see how the electricity works within your body. So what are some of the secrets that I can reveal to you today? Well, the neurological thought process is pretty unique when it comes to medicine. We think about localization. We think about where is a problem coming from. And then we think in terms of the central nervous system, in terms of the peripheral nervous system, and we even think in terms of the autonomic nervous system. This is the part of your nervous system that gives that flight or fright idea, the idea that you have to be running away from some sort of predator that's coming after you. And nowadays, that idea that you may be sweating or may not be sweating, you'll have changes in your pupils, we call that the autonomic nervous system. And then we may think that what you're describing is not neurological. Next, what we'll try to think about is what is causing it. What is actually the cause of the problems? Somebody could have weakness, and it can be caused by something like multiple sclerosis, but it can be caused by other sorts of things. It can be caused by a problem that you had at birth. It can be caused by a problem you had even before birth, such as cerebral palsy. It can be caused by a problem you have later on in life, such as a stroke. And so we have to go and look at those things that are happening to you and think about, is it happening from the nervous system or not? And then what part of the nervous system is involved? When we're thinking about dealing with multiple sclerosis, we use something called the triple threat. the 3 MS-keteers. And there's a great support group for MS in Deltona, Florida, and they use the name MS-keteers. And they let me years ago start to use that name when I'm describing the 3 ways that we treat multiple sclerosis. We try to think about disease-modifying agents or disease-modifying therapies. We think about in terms of symptomatic treatment, and we think about what happens in terms of acute exacerbation treatment or relapse treatment. Now, much of the time when you hear talks having to do with multiple sclerosis, you're going to hear a focus that has to do with disease-modifying agents. And remember that before 1993, there were 0 FDA-approved treatments for multiple sclerosis that were disease-modifying therapies. And now we have a lot of disease-modifying therapies. We have medications that are self-injectables, that are subcutaneous or into the muscle. We have medicines that are IV into the vein. We have medicines that are pills that people take orally as well. And so we have lots of ways of trying to prevent relapses from happening in the first place. But that's not our focus of what we're talking about today. We think of those medications as being proactive medications, as being ways of trying to stop something from happening in the first place. And the goal of these disease-modifying therapies, disease-modifying agents, or disease-modifying drugs are to prevent relapses and hopefully to prevent progression of physical and cognitive disability. No diet, unfortunately, has been proven to do this definitively, and as yet no supplement or vitamin has been proven to do this. We were very close to having a vitamin that we were hoping was going to help a lot with disease-modifying treatments, and unfortunately, the results that we've seen thus far have not been as hopeful as we had hoped. When we're thinking about this triple threat, we not only think about disease-modifying treatments, we also think about what happens during a relapse. And so this is not just talking about what happens in between relapses and preventing them, but what do you do when you're having more of those problems? And that's what you see by these bars where they go up. You're seeing more problems happening, more problems having to do with the central nervous system. And what's in a name? Other terms for relapses are exacerbations, not exasperations, as we said, flares or attacks. And it's important when we're thinking about a relapse to remember what we think it is and what we think it's not. We think it's new or worsening of neurological symptoms that are consistent with MS. So if it's something that looks like carpal tunnel, well, that's not really consistent with multiple sclerosis, and so we're not going to call that a relapse of multiple sclerosis. Not everything that happens to a person with MS is considered an MS relapse. They're either going to be subjectively reported by the person, or they're going to be medically observed. Of course, when they're also medically observed, that can be even better. And so if you can get into a neurologist when you're having a relapse, that can be even better, because then it's not just what you described, it's what we actually see on our physical examination. And these are going to be individual or combined symptoms that last for at least 24 hours. So things that come and go very quickly within 24 hours, so things that will just last for a few seconds to minutes to hours, we don't think of as MS relapses. We think that these have to be separated by at least 30 days from the previous problem. And so we don't think that you can go on and have a relapse after relapse after relapse, day after day after day. We may count those all together as one relapse, but we're not going to say that you had 15 relapses in a row. You also have to make sure that you don't have what we call a pseudo-relapse. A pseudo-relapse does not mean a fake relapse in that you're faking. What it's saying is that your body, for some reason, and often this is from overheating, is bringing out older symptoms that look like symptoms of multiple sclerosis. And these are reversible worsening of symptoms that can be associated with increased core body temperature. And this can happen because of fever, it can happen because of vigorous exercise, it can happen because of a hot water bath or showers. And in fact, one of the tests for multiple sclerosis many years ago used to be we would place people with multiple sclerosis into hot baths to see if they came out more noodly, if they became weaker and kind of more flimsy around. This is something that would reverse, but it was a way the neurologists, well before they had MRIs and other sorts of testing, used it to help in the diagnosis of multiple sclerosis. Environmental heating can be important. And so, especially in places in the South, it's not just the ambient heat from sunlight, it's also the humidity that can bring out older symptoms and cause what we call a pseudo-relapse. And stress. Stress can be an important factor in multiple sclerosis, just as in almost everything we do day to day. And I know we're all living with more stress. All of our stress levels are higher. But when somebody has an increased amount of stress, it can bring on and out symptoms that may look like an MS relapse but aren't. So what are examples of MS relapses? Well, if you go to Dr. Google, almost anything can be an example of an MS relapse. Problems with sensation, problems with vision, more fatigue, depression, more spasticity or tightness, more balance problems, more weakness, cognitive problems, pain, emotional dysfunctions, bowel or bladder problems. Almost anything that you can think of that can have to do with multiple sclerosis can be an example of an MS relapse. Why do these relapses happen? Well, they happen in most people with MS, and that's because we think of it as the hallmark of MS, that the body's defense forces, the immune system gets through the blood-brain barrier and causes inflammation or swelling inside the central nervous system. There are some factors that may contribute. If you don't take your disease-modifying therapies consistently or as prescribed, well, the whole point of those medications is to prevent relapses. And if you're not taking them like you're supposed to be, well, you could have more relapses. Seasons of the year, and sometimes in the summer months, people will have more problems, and other times in other parts of the year. Vitamin D status. And that's why what we'll see sometimes is in the winter when there's less vitamin D around, people may even have more relapses happening. Physical or emotional stress or trauma, we talked about how that can be a pseudo-relapse, how stress can cause it, but stress can also start out, well, it starts out as a pseudo-relapse and then becomes a full-fledged relapse itself. Infections. Urinary tract infections can start out what looks like a pseudo-relapse or a not true relapse, and can actually cause an actual relapse to happen. There's some debate about whether live vaccines can or can't. Less and less we're thinking they do, and more we don't use live vaccines. Even now for shingles, we have a vaccine that is not a live vaccine. Smoking. We know that smoking can lead to more disability with MS, more relapses. If you're still taking self-injectables, can lead to more skin site reactions. And as I said, it can lead to more relapses. What do you do if you suspect a relapse? Well, you should talk to your doctor before the relapse happens. You should find out from your doctor, what is your plan for you? What's going to happen in your environment? You may live in a big city, you may live far away from the doctor, you may live very close. These are things that you want to have a conversation with before it happens. What are you going to do? You should have a relapse plan. You should communicate your symptoms to your doctor. And often you will need to be seen by your doctor, but that's not always going to be possible. Your doctor may take your history and examine you, and then may order lab tests, especially to make sure you're not having an actual infection that can lead to what we call a pseudo-relapse. For example, they may check your urine to make sure that you're not having a urinary tract infection. Sometimes an MRI may be ordered to help document a relapse, especially when it's confusing to the neurologist. Now, oftentimes people will tell me that their symptoms are coming and they feel, for example, that they have sensory problems. So they feel on their arm or their leg, they feel sensation difficulty. And they'll have an MRI of the brain and it won't show a problem. And the problem with that is that the brain may not be the reason for those symptoms. Those symptoms may be happening because of the spinal cord. And I like to compare that to when you break your arm and a doctor does an x-ray of your foot. You can do MRIs, but if you're not doing MRIs of the right part of the central nervous system, it's not necessarily going to show a problem. But MRIs can be helpful. I just want to show these to you so that you have an idea if you haven't seen your own MRIs. What you see here is what we call a T1 weighted image with gadolinium. We have here a T2 weighted image. And then the more common one that we looked at is something called The more common one than the T2 is something called a flare or flare attenuated inversion recovery. But the final one that you see here is T1 weighted image without the gadolinium. So it's before we gave the dye. And then where we see that area with the brightness with the dye, that can tell us that it's not just an old lesion that happened, but that there's a new problem happening right now. I want to give you an example of a relapse that people may not think about. And in fact, this person went on for a long time going to different doctors before they had their actual diagnosis that they were having a relapse. This is a 42-year-old woman with relapsing remitting multiple sclerosis who has 3 weeks of urethral pain. So she has pain that sounds like it's coming from her, from the areas of her body where she's going to try to urinate. She saw a gynecologist as well as urologists, and they couldn't find anything causing her pain. She has been smoking cigarettes since she was 12 years old, and remember that we said cigarettes is a risk factor in multiple sclerosis. And on examination, she had a spinal cord sensory level, so a detailed, careful examination of her nervous system showed that she had what seemed like a lesion at the level of T7. So thoracic area 7, where she had decreased vibration and sensation, decreased vibration and proprioception, position sense in her feet, and she had higher reflexes in her knees. We've known for a long time that cigarettes are a problem in multiple sclerosis. And what you see here is that back in 1964, even in March, we knew that there were problems with smoking, and that smoking could lead to MS relapses. In this person, she had an MRI of her thoracic spinal cord where it looked like her symptoms were coming from. It didn't seem like her symptoms were coming from her brain. So the MRI wasn't of her brain, the MRI was of her spinal cord. And in fact, if you look here at the areas pointed to with the red arrows, you can see areas that light up, areas where there's going to be more brightness. And that's the areas where actually when you give gadolinium, you give that dye, what you can actually see is that it was a new problem going on. She was having an MS relapse in her spinal cord that was causing her urethral pain. So something that might not always be thought of as a symptom of a relapse could actually be a symptom of a relapse. What is your doctor going to talk to you about doing during this exacerbation, during the relapse? Well, we might use corticosteroids, and these are going to be steroids such as IV methylprednisolone or solumedrol, IV or oral decadron or dexamethasone. We used to talk about oral medrol smoothies where we actually mix the solumedrol. Solumedrol is called solumedrol because it's soluble, meaning you can mix it in water and in other kinds of beverages. We now have more data than we used to have that higher doses of oral prednisone could actually work as well as IV steroids as well in stopping an MS relapse. But many of us still do not feel comfortable using things such as a medrol dose pack. We think those are too low doses of steroids for MS relapses. And in fact, in a very important study called the optic neuritis treatment trial, they led to even more relapse problems than people who weren't taking any medicine at all. We also may think about something called intramuscular or subcutaneous adrenocorticotropic hormone or HP-Acthar gel. And we may think about things that are not FDA approved, such as IVIG or intravenous immunoglobulin, or even plasmapheresis, which is sort of like dialysis for the blood, where what we're doing is we're cleaning out the blood. And the things that are FDA approved are going to be the steroids or using the ACTH. Oftentimes you'll see a treatment plan such as this one, where a neurologist may give a gram or 1,000 milligrams IV intravenously of solumedrol in normal saline. They'll infuse it over 1 hour into the vein for 3 to 5 days. Some doctors may give oral steroids afterwards as a taper, and some don't. Sometimes even you may get the first when you come into the emergency room, and then the rest will be arranged for as a home infusion, where nurses will come to your house to do them. So who shouldn't get infused at home? Well, people who have had psychosis because of steroids, people whose diabetes is out of control because their blood sugars will get even more out of control with the sodium medrol. If Medicare, and Medicare is getting much better about covering different things, but if their Medicare doesn't cover it, and if they have an unstable clinical course, and there's other reasons why someone might want to be hospitalized, those are people we wouldn't treat at home. On the other hand, will we use ACTH, the other way of treating with an FDA-approved medication? Well, according to the Food and Drug Administration, whenever there is an MS relapse, ACTH is usually reserved for people who do not fully recover from their relapse using steroids, or people with side effects from steroids. And a much less common reason is people who have problems getting an IV. As I've said, we've had a lot more studies that show that taking steroids orally can work just as well as taking it IV. And so that's where things have changed. So how do the relapse treatments work? Well, corticosteroids or steroids reduce inflammation. They bring down the swelling that's happening. We think that ACTH does that, but also stimulates your adrenal gland to produce natural steroids, and they can have effects on the melanocortin receptors found in your immune system and on nervous system cells. And so those are where we are in terms of treating MS relapses. We need to do a lot more research to get a lot better. The reason why there's less research going on to MS relapses than there is in, say, disease-modifying therapies is that if we're doing a good job of disease-modifying therapies, then that means we're having less relapses. And as we've done better and better, and we've had new disease-modifying therapies that are doing a better and better job of reducing the number of attacks that you're having, we'll have had less need for treatments for those attacks. I want to talk very briefly about the third MS criteria. We talked about disease-modifying agents, acute exacerbation treatments, but we also should talk about symptomatic treatment. And that's most of the time that you have MS. And so when we think about MS symptoms can be almost anything that you can think of that can come from the nervous system. Now, I like to think about MS symptoms in terms of things that you can fix if needed. And we think about them in terms of visible symptoms, invisible symptoms, and private symptoms. And so, for example, if you're having problems walking, that's a visible symptom. Other people can look at you and say, well, you're not walking right. That may be a symptom of multiple sclerosis. If you're having fatigue, or you really can't move and you're really feeling either cognitively fatigued or your muscles are feeling fatigued or tired, extreme tiredness, then that can be an invisible symptom. But if you're having problems that have to do with urination, that's something that's not just invisible, but that's something that someone who lives with you knows about. So it's not invisible to others, it's just invisible to most people who meet you on the street. And that I like to call a private symptom of MS. I think it's important to think about these symptoms in terms of these buckets, is because then you have a better understanding when you're going into a neurologist's office what we know about and what we don't know about, what things we can see and what things we can't. Remember that your neurologists only know about things that you're going to talk to them about. And so bring up those topics. Make the office visit your office visit. Have 3 things that are very important to you that you want to talk about at the visit. Talk about them before your doctor gets to all the things that they want to talk about. Remember that picture of Dr. Google and all those different relapses of multiple sclerosis? Well, those can also be symptoms of multiple sclerosis. And those will have to be addressed in multimodal ways. We have to use communication, education. We may use physical therapy, occupational therapy, other physical modalities. We may use medications. We may have to understand better about what sorts of factors can lead to those symptoms. Is it extreme heat? Should you be taking a cooling vest? Should you be calling up MS Focus and seeing if there is a cooling vest program that might be available for you? What other ways can you improve your life? It is only by motivating, educating, and empowering that you can become a better you. And that's why this multiple sclerosis team approach rule is so important. But it's so important for another reason. When we think about each person with MS and this team around them, we really should think about how we all come together for this idea of patient care this idea of education like we're seeing today, as well as research. But the community becomes even more important. And in today's tough times, it's even more important for us to look at our community. We've seen the MS community rise up like never before during natural disasters, and this is no different, where we have people with MS helping other people with multiple sclerosis. We see each of these M stars coming together and finding a way to help each other. By each team helping another team, we can truly come to this idea of a multiple sclerosis patient network, the idea of one group of people helping another group of people. And the good news for all of us is that there's more research in MS than ever before. We've seen an asymptotic increase in research. More and more MS research is going on than we've ever seen before. And every day we're learning more about multiple sclerosis, how to treat it, how to understand it better. And hopefully, with programs such as this, as well as with each individual M-STAR team, we can make the multiple sclerosis team approach rule turn into the multiple sclerosis team approach reality. With that, I'd like to thank the Multiple Sclerosis Foundation, MS Focus, for all of its work that's done throughout the years. I want to thank all of the people who are helping to support us here on this phone call by making sure that the computer works correctly, that sound comes through correctly, and I'd be more than happy to take any questions that people may have. Thank you very much.
Thank you, Dr. Kantor. Well, let me tell our listeners how they can ask a question. You have a couple of options. First of all, depending on which version of Zoom you are using, you may have the raise hand button. To find that, touch your screen or click on your screen if you're using a mouse and go to the option that says More. It has 3 little dots, and there you should see the option to raise hand. That will allow us to know that you have a question you would like to ask and unmute your line and bring you on to ask the question. If you don't have that option or if you don't see it, you can use the chat function. It's also on your toolbar. If you touch your screen or click your screen, you'll see a little chat bubble, and you can either type your question in the chat or just type, "I have a question." We'll find you and bring you on the line. All right, so if you have a question, now is the time to hit that raise hand button or hit us up in the chat. Dr. Kantor, one quick question I had. You said that ACTH is often used for people who can't tolerate IV. Does that mean that ACTH is an oral drug?
ACTH is given either into the muscle or subcutaneous, so an injection under the skin.
An injection, okay. All right. Do we have any questions? Let's see. All right. We don't have any raised hands at this time. So, Dr. Kantor, if there is one major thing you wanted people to take away, what would that be? What's your main take-home point you'd like people to have today?
The main take-home point is that I think people should have a plan with their neurologist about what to do in the event they do have a relapse. Everyone's story is different. So some people have had a relapse 20 years ago and that's it. They had 1 or 2 relapses. Other people are having relapses more frequently. But it's important for everyone to have an idea with their neurologist what's going to be the plan. You don't want it to be, it's a weekend and you're having problems and you're not sure what to do because you've never talked to your neurologist about what you're going to do. And so I think it's a worthwhile conversation to have with your neurologist, to talk to them about your disease-modifying therapy, to talk to them about your symptoms, but also to talk to them about your relapse plan.
Okay. We have a great number of questions popping up now. Let's see. Antoinette says, the eye doctor shared information that prednisone or solumedrol can cause cataracts. Is this true or false?
The issue is that corticosteroids or steroids The reason why we're not using them all the time, lots of times over and over and over, is because there can be untoward side effects. So some of those side effects can be things like problems with bone health. And there can even be a bone problem that can happen at any point when someone takes steroids. Other things involve weight gain. Other things can involve changes in your blood sugar. They can make you more likely to have an infection. They can reduce your immune system as well. And other things they can do is they can affect your vision in different ways. And steroids over time can lead to things like cataracts. And that's why our goal in multiple sclerosis is not to treat every relapse and just treat relapses. Our goal is to try to prevent you from having a relapse in the first place. The best way to treat MS relapses is to stop you from having them in the first place.
Okay. Our next question from Antoinette is, are steroids immune suppressant?
The question was, are steroids or corticosteroids, are they immunosuppressant? The word immunosuppressant in America has an interesting history because a lot of compounds that some people may consider immunosuppressant, we sometimes don't talk about them in terms of that. But if we mean that if you have your immune system fighting off infections and you're pushing it down by taking something, well, in that case, yes, that's what steroids do to a certain extent. Steroids can make you more likely to have an infection. Now, with that said, we use steroids a lot of times in the setting of an infection, and that's because we want to also reduce inflammation. And so steroids, and especially steroids over long periods, can make you more likely to have infections, and that's why we don't want to keep people on steroids for a long time.
Our next question is from Veronica, who says, I really have a problem with spasticity. What can I do?
The question was about spasticity. Spasticity or muscle tightness. For some people, that can feel like Charlie horses where they feel a tightening happening. For other people, it can mean that it's just harder to move, and it can become a lot harder to move. It can affect the way people walk, affect the way people move their hands, it can affect other parts of their body as well. We usually think of spasticity as not a relapse. It's not something that's coming on and going away. We think of as spasticity as a symptom of multiple sclerosis. It's a symptom that can be made worse by certain things. So oftentimes heat can make it worse. Some medications, especially ones that we used at the beginning of multiple sclerosis treatment, so the interferons can sometimes make spasticity feel worse. Some people, though, do use that spasticity to their advantage because they also have weakness. So the spasticity, the muscle tightness, means that they're going to be able to stand up straight. They're going to be able to stand because their muscles are tighter. Even though they're weaker, they may be tighter. And so when we think about treating spasticity, you start out with things like exercise, things like physical and occupational therapy. You can think about things like acupuncture. You can think about things like yoga and Tai Chi. Then we think about other things like medications, and it doesn't mean you have to do one thing or the other. You should do probably these things together. We think about medications, oral medications that we use, such as baclofen is the most commonly, and we're studying other versions of baclofen to try to see if we can bring down some of the side effects as well as make you not have to take it quite as often as you have to take that medication. Then we have other ways that we treat spasticity by even being more invasive. We can do things like injecting actual toxin, so things like botulinum toxin that can weaken muscles and that way bring down spasticity. And even in some people, we may place something called a baclofen pump. And that's a pump that what's going to happen is it's in your body and it pushes that baclofen into your spinal column, not your spinal cord, but your spinal column, and releases that medication. So discussing spasticity is a very important topic to talk to neurologists about. They may handle it all their own. They may say, well, we want some help from physical therapists. And they may say, well, we want some help from a specialized type of doctor called a physiatrist or a physical medicine and rehabilitation doctor that also can help with treating spasticity.
Okay. I'm going to try and bring one of our callers on the line. JC said there was a question. Let's see if we can get you unmuted. and it's not cooperating. So, JC, if you want to give your question in the chat, that would be great. It's another question that's somewhat related to spasticity, Dr. Kantor. Caroline says cold really bothers her spasticity. She said, you mentioned that heat can initiate a relapse. Is it possible that extreme cold can have the same effect?
So we don't usually think even of heat as starting a relapse. We usually think of heat as being safe, but just uncomfortable. But you are right also that while 70% of people with MS can be affected by heat, there's going to be 10% or more that are actually going to feel worse in the cold. So not necessarily starting a relapse, but it can bring out other sorts of symptoms. Of course, the body gets stressed by different things. And so if your body is stressed by cold, especially if you have other things going on, such as arthritis, where cold can make that worse, well, then that can become a vicious cycle that can happen.
Okay. Going back to your previous comment about a physiatrist, Antoinette comments, I had asked my doctor about the physiatrist and he blew me off. It seems like a good theory, but has anyone worked with one before? Where do you find a physiatrist in Georgia?
I'm not sure if the question is only to me about in terms of has anybody worked with them. I've worked with a lot of physiatrists. Georgia is a very large state. There's metropolitan Atlanta where there's lots of people, and there's physiatrists even at MS centers, such as there's the MS Center of Atlanta, there's the Shepherd Center for multiples, there's the Shepherd Center, and then there's other physiatrists as well at different institutions. More in rural Georgia, it may be harder to find a physiatrist who's in your area. One way to do that is to go on to the website, especially of your insurance company, and see which doctors are covered. If there is a rehab hospital or a physiatry hospital in your area, then you may want to call them and find out about it. And that's something you may want to talk to your primary care physician about as well. Oftentimes, primary care physicians are deeply rooted in communities, and they may be more familiar about who is and who isn't practicing in their area.
One of our commenters says, I'm a physiotherapist and have seen some clinical studies using electrical stimulation during the exercise with good results. What is your opinion about that?
The question was about using electrical stimulation. Electrical stimulation is very interesting. In some parts of the world, electrical stimulation is used a lot more than in the United States. For example, in the former Soviet Union and Russia, electrical stimulation is used. We use electrical stimulation here in America a lot of times when people are having massages after physical and occupational therapy or after chiropractic medicine. Sometimes people have even the use of electrical stimulation to help them with walking. There's some sorts of walking devices such as the walk aid, which actually uses an electrical impulse to help lift up your foot when you're walking. And other people may use something called a TENS, or a transcutaneous electrical nerve stimulator. And so these are pocket-sized devices that have electrodes, and those electrodes you stick to your body, and then you cause that sort of electrical stimulation. I really think that using exercises while also doing electrical stimulation can be very beneficial to a lot of people, and in some ways it can retrain the nervous system, retrain the way the nerves and muscles communicate with each other.
All right, thank you. I want to remind our listeners that you can touch your screen or click your screen to pull up the toolbar at the bottom. Under the button that says More with the 3 dots, you can find the Raise Hand button. If you don't see that and you'd like to ask a question, you can click on the Chat button and type your question. Now we have a question from Jan. Jan, you're on the line.
Thank you. Dr. Kantor, talking about flares a little bit, does a flare bring on a new symptom? For example, for me, that feeling of falling back is a new symptom, and it generally comes along with not feeling well, etc. I can almost guarantee that the next time I kind of feel that feeling of that falling back, it indicates that I'm not feeling well. Something is going on. So can that new symptom, or can that flare be a new symptom?
Yeah, oftentimes flares or exacerbations or relapses are new symptoms. And in fact, it's much easier to tell an exacerbation when it's a new symptom. When it's an older symptom, it becomes harder to know whether you're just having a return of a symptom that you've had for a while. But a new symptom, something that you haven't had before and then comes on, is kind of more classically what we call a relapse or attack of multiple sclerosis. So remember, we think that you're basically stable beforehand. The official definition of research is that you have complete stability for 30 days. With that, I recognize a lot of people with MS aren't ever exactly completely, stable from the neurological point of view. So things are basically okay, and then something new has happened, and we think of that as a relapse.
Thank you.
All right. We have a question in chat. Judy says, hello and thank you. Can you talk a little bit about MS and white matter and gray matter?
Oftentimes in MS, we've talked a lot about MS affecting the white matter. We talk about white matter lesions and multiple sclerosis. So first, what are we talking about? Well, when you look at the brain, so when you actually look at what a human brain looks like, there's areas that look grayer, and that's around the outside. We call that the cortex. And then there's areas, and there's areas that communicate where there's wires and there's covering of the wires called myelin, and those are fattier, and so they look whiter. And that's what we call white matter lesions. So in MS for a long time, we talked about the MS lesions being inside that myelin. What we've learned is something that we've known for over 100 years. Back when Charcot in France described MS, he already described it as affecting not just the white matter and gray matter, but for a long time, for decades, we talked a lot about the white matter. More and more, we're focusing on the gray matter as well. And the gray matter is where we actually think of the center of the nerves. And that's where we think about things like cognition or things like thinking coming from. And so we're learning more and more about how gray matter is affected. And in fact, people with multiple sclerosis, when we do even more specialized MRIs than are available, research-grade MRIs, we can actually see lesions that aren't just in the white matter, but are also in the gray matter.
All right. Our next question is, I have problems with sleep, and I've been on Ambien for years now and cannot sleep without it. Do you have any suggestions about problems with sleep in MS?
Yeah, so in America, the most commonly problems with sleep are the same as the most common problems with sleep with somebody with multiple sclerosis. And that's poor sleep hygiene, meaning we don't use the bedroom for what it's intended for, especially nowadays with everyone staying home and everything. But the bedroom's intended for two things, and one of them is sleep. The other one is not watching TV and not eating. And yet we've done that, and so we've disrupted our sleep. We've changed the way we sleep. We also, as our necks have gotten larger, and even without larger necks, we've had problems with sleep apnea, with problems with not breathing right while we sleep. And so I recommend, if you're having a lot of sleep problems, talk to your neurologist and your primary care physician, but to also probably make an appointment to actually see a sleep physician. So a sleep neurologist or a sleep pulmonologist, somebody who is specialized in the area of sleep. Because you don't want to be taking medications all the time, and you wouldn't be asking that question if you wanted to. And so the question is there an underlying sleep problem aside from the multiple sclerosis that might be leading to that, and how can you best address it? And so you may need to have an actual sleep study. And sleep studies involve two things. One of them is when people sleep overnight at a facility. The other one is the next day when they have what we call nap studies to see how fast you turn into a nap. And we're looking for things like narcolepsy, frankly, where you fall asleep instantly. And other people may not even know that. Other people may have problems where they're having problems breathing in the middle of the night, and they have apnea. And that may come from the problems with breathing, but that may come from problems inside the brain as well. And so that's why it's important to get your sleep diagnosis made so we can figure out the best way of treatment.
Another related question. Antoinette says, I've read some medical papers about the increase in vitamin D being directly related to a decrease in melatonin, which affects sleep. Now, we know many people with MS are told to take vitamin D by their neurologist. Is there an issue there?
We don't think that people with vitamin D who are just getting regular vitamin D supplementation, it does not appear that they're having more problems with sleep. And so it doesn't seem like it is an issue. You brought up melatonin. Some people do take melatonin over the counter to try to help with sleep. And some people taking that half an hour before sleep is something that does seem to be beneficial.
Okay. Well, thank you so much, everyone, for your questions. Thank you, Dr. Kantor, for your presentation and your generous giving of your time to answer our questions today. I do want to let everyone know that if you missed any part of this teleconference, that it will be made available on the Foundation's YouTube channel. It usually takes 1 to 2 weeks for the conferences to be posted. So if you would like to know when that happens, we recommend that you follow us on Facebook, Twitter, or Instagram. We always post when new material or content is available. We do also have further teleconferences coming up during this time of social isolation. We're trying to keep everyone engaged as much as possible. We've been having usually several teleconferences a week. Our next one is going to be actually on a subject we talked about a little bit today. It's Tuesday, June 2nd at 2 p.m. That's 2 p.m. Eastern. Megan Weigel will be talking about integrative approaches to sleep. So we hope you'll join us, and we sincerely thank you for joining us today, for your participation. And especially I'd like to thank Dr. Daniel Kantor for all of his time and information that he shared with us today. Thank you, Dr. Kantor.
Thank you. Take care, everyone.